Good afternoon, everybody. This is Stephanie Hall, and I am with the ESRD NCC National Coordinating Center. Thank you so much for joining us today for the ESRD NCC Professional Education webinar event. As you know, these events are being held in partnership with the Centers for Medicare and Medicaid Services. The series of events feature guest speakers from around the country sharing how they or their organizations they are with are coping with COVID-19. Before we get started, I wanted to let you know this call is being recorded and will be posted to the NCC COVID webpage within 3 business days. Next slide. So just a little bit about the agenda. Talked about what this call is about. Today we have actually a little panel. We have 3 speakers today. Dr. Bardossy, Dr. Novosad, and Stephanie Booth, all from the CDC. I'll be doing their introductions in just a moment. The topic today will be updates on COVID-19 for dialysis frontline staff. Everybody's attendee lines have been muted upon entry, but we do want to hear from you. So we ask that you submit any questions for the speakers through the Q&A or the chat. And at the end of the presentation, we will get to answer as many questions as time allows. Next slide. So what is this call about? These calls are held bi-monthly on different varying topics. We hear from different stakeholders and peers in the ESRD community who are adapting to the COVID-19. They are sharing examples and providing real-world strategies for facilities to use. Next slide. So let me go ahead and introduce our speakers. Our first speaker is Dr. Bardossy. Currently, she serves as the medical officer on the dialysis safety team in the Division of Healthcare Quality and Promotion at the Centers for Disease Control and Prevention. She joined CDC in 2018 as an Epidemic Intelligence Service Officer in the Prevention and Response Branch. Prior to her work at CDC, Dr. Bardossy worked in infectious disease research at a large academic healthcare institution in Michigan and as a hospital epidemiologist and an infectious disease physician in Argentina. Her areas of interest are infection prevention, the control of outbreaks, and healthcare quality improvements. Next, we have Dr. Novosad. She is a medical officer in the Division of Healthcare Quality Promotion at the CDC and currently serves as team lead for the dialysis safety team. In 2015, Dr. Novosad came to CDC as an Epidemic Intelligence Service Officer assigned to the DHQP, where she investigated outbreaks in healthcare settings. Her areas of concentration include central line associated bloodstream infections and infection prevention in the dialysis setting. Also, we have Stephanie Booth. She is the infection prevention educator for the Making Dialysis Safer for Patient Coalition. She has a degree in healthcare administration, a certification of infection control, and is contracted in the Division of Healthcare Quality Promotion at the CDC. Stephanie's expertise relies heavily on her 15 years experience in the dialysis setting as a certified tech, a biomedical tech, coordinator, and educator. So we welcome our team, and I think Dr. Bardossy, are you up first?
Yes, hi, I will start. Thank you, Stephanie. Thank you for the introductions and for inviting us to speak today. We'll summarize critical information that has been updated or released in the last few months. Some of you may already be familiar with this information that I will present today, but we think it's important for us to review and to ensure we remain diligent. Next slide, please. There are 2 websites that are important to be aware of and house infection control guidance that applies to dialysis facilities. The first is the CDC main infection control guidance for COVID-19 that has general recommendations for all healthcare settings to be used when caring for patients with suspected or confirmed SARS-CoV-2 infection. Next slide, please. The second one is the infection prevention and control recommendations that are specific to dialysis facilities. intended to supplement, not replace, the general IPC guidance. It is important to periodically review both the main and the dialysis-specific guidance, and today we'll review important and recent updates from these two websites. Next slide, please. We'll start with the dialysis webpage. As we can see here, the webpage provides links to different guidance documents and other resources. On the left navigation panel, you can find the main infection control guidance for dialysis facilities, but also guidance on patient screening, acute care dialysis, home dialysis, and testing. In the middle, we find these links, as well as the link to cleaning and disinfection of transport vehicles. On the right are the links related to SARS-CoV-2 testing. The first one is specific to testing in dialysis facilities, and then additional links for testing of healthcare personnel and antigen testing. Next slide, please. The guidance for testing dialysis patients is one of the most recent guidance documents added to our website towards the end of last year. Next slide, please. This site includes recommendations for testing patients with signs and symptoms of COVID-19, recommendation for testing asymptomatic patients with known or suspected exposure to an individual infected with SARS-CoV-2, and recommendation for testing to determine resolution of infection. Next slide, please. There are two things that are important to highlight from this testing guidance. First, that testing conducted at dialysis facilities should always be implemented in addition to infection prevention and control measures. And second, we know that not all dialysis facilities can perform on-site testing. However, all facilities should have a plan for testing patients for SARS-CoV-2. For example, identify where patients will be referred for testing if the dialysis facility cannot perform on-site testing. Next slide, please. The recommendations for testing asymptomatic patients are important to consider because they address what facilities should do if they have an outbreak in their facilities. We first recommend to consider performing expanding testing of all patients and healthcare personnel in the dialysis facility, or at least of all patients and healthcare personnel that had dialysis treatments or work on the same shift or day than patients with recent onsets. A possible outbreak in dialysis facilities is a hard situation to confront because, unlike patients in nursing homes or acute care hospitals, dialysis patients can be exposed outside of the dialysis facility, and identifying if transmission occurs within the facility can be challenging. SARS-CoV-2 infections among healthcare personnel or patients with epidemiologic links within the dialysis facility and no other identified exposures suggest that transmission may have occurred within the dialysis facility. Any transmission within the dialysis facility should be considered an outbreak. So it is important to be ready to perform testing as soon as transmission within the facility is suspected. In this way, infected patients will be quickly identified, assisted clinically, and IPC measures can be implemented. Next slide, please. In addition, facility-wide testing might identify asymptomatic and pre-symptomatic patients with SARS-CoV-2 infection, so facility leadership should be prepared to continue to provide dialysis and isolate patients as needed. It is important to emphasize that healthcare personnel should also be included in the testing as part of the response to the outbreak. And if viral testing capacity is limited, additional considerations can be used to direct the testing. For example, if cases are identified in patients on a particular dialysis schedule or shift, for example, Monday, Wednesday, and Friday, testing could be performed in all patients on that schedule instead of facility-wide. Here is a website that has some consideration on how to perform raw testing for congregate settings that can be useful. And lastly, we wanted to remind that suspected or confirmed outbreaks in dialysis facilities should always be reported to local public health authorities. Next slide, please. The last section of the testing guidance addresses testing to determine the resolution of infection and recommends that in general, a symptom-based strategy should be used to guide the decision on when to discontinue transmission-based precautions, and includes the link to this guidance that you can see in the slide. This guidance recommends using a symptom-based strategy for patients with confirmed SARS-CoV-2 infection with mild to moderate illness who are not severely immunocompromised, meaning to discontinue transmission-based precautions after 10 days have passed since symptom onset if patients have at least 24 hours without fever, without the use of fever-reducing medications, and if symptoms have improved. Next slide, please. And for patients with confirmed SARS-CoV-2 infection with severe to critical illness, or who are severely immunocompromised, to discontinue transmission-based precautions at least 10 to up to 20 days since symptoms appear, in addition to the lack of fever for 24 hours and improvement of symptoms. We know that dialysis facilities are a unique healthcare setting in which nephrologists and healthcare providers are not always on site at the moment that the patient is receiving dialysis. However, it is important that clinicians and nephrologists support the frontline staff and help determine when a patient fits criteria for discontinuation of transmission-based precautions. Next slide, please. Now, we would like to highlight some other resources that are available on our website, even they are not new resources. There is a link in the infection control guidance for dialysis facilities to a dialysis facility preparedness assessment tool. It is formatted as a checklist that you can see in the slide. It is a useful tool that can help ensure dialysis facilities are prepared for potential arrivals of COVID-19 patients. Even if your facility has used this tool before, it may help to repeat the checklist periodically to ensure that no practices or procedures have been lapsed or been overlooked. Next slide, please. At the bottom of the dialysis webpage, you will also find the training videos that have been developed specifically to train frontline staff in dialysis facilities. There are 3. Next slide, please. The first one that includes basic steps on infection prevention. Hand hygiene and environmental cleaning are included in this video. Next slide, please. The second one about personal protective equipment used in dialysis facilities. Next slide, please. And the third one that includes steps for screening patients before dialysis treatments and appropriate patient placement. Next slide, please. At the bottom of the infection control page, there are links to several other resources, such as fact sheets, handouts, and a presentation for facilities titled Preparing Outpatient Hemodialysis Facilities for COVID-19 that can be useful resources. Next slide, please. And now, let's switch our attention back to the general IPC guidance and review what updates have been recently added. It is important to mention that since these guidance documents are updated periodically, there are 2 sections that can be very useful to help you track of recent updates. In the right picture, the first red box highlights the summary of recent changes. And below that, there is a second link that allows access to previous updates. These 2 sections are included on all guidance documents, and it may be useful to review those 2 parts periodically to stay updated. Next slide, please. There are numerous FAQs available on the webpage, and we want to highlight one here. This FAQ is the clarification on whether it is possible to reduce the 14-day quarantine for patients receiving healthcare and healthcare personnel with exposures to SARS-CoV-2. This was issued due to new guidance that applies to the community setting that offers different options for discontinuing quarantine, including ending after day 10 when no symptoms are reported, and day 7 in the setting of a negative test and no symptoms. However, for healthcare settings, their recommendation has not changed, and the optimal choice is to continue to use a 14-day quarantine. We have highlighted in red the key parts of this text. As you can read in the second paragraph, healthcare facilities could consider those alternatives as a measure to mitigate staffing shortages, space limitations, or PPE supply shortages. But due to the special nature of healthcare settings, such as patients at risk for worse outcomes, critical nature of healthcare personnel, challenges with social distancing, the alternatives are not a preferred option. Shortening the duration of work restriction or patient quarantine might pose additional transmission risk. Next slide, please. A second update located in the general IPC guidance is related to the screening and triage of patients, healthcare personnel, and visitors entering a healthcare facility. Options could include these, but are not limited to individual screening on arrival at the facility, or implementing an electronic monitoring system in which prior to arrival at the facility, people report absence of fever and symptoms of COVID-19, absence of a diagnosis of SARS-CoV-2 infection in the prior 10 days, and confirm that they have not been exposed to others with SARS-CoV-2 infection during the prior 14 days. Some dialysis facilities may choose to implement this in a variety of ways, such as having someone call the patients prior to the treatment, stationing someone at the entrance to screen and triage, or by using approved texting apps to communicate with patients prior to their treatment time. Next slide, please. It also includes a section clarifying considerations about the fever and the measurement of temperature that can also be useful. Next slide, please. Lastly, one of the other recent updates is about the process facilities need to have in place to respond to SARS-CoV-2 exposures among healthcare personnel and others. Healthcare facilities should have a process for notifying the health department about suspected or confirmed cases of SARS-CoV-2 infection and should establish a plan in consultation with local public health authorities for how exposures in a healthcare facility will be investigated and managed and how contact tracing will be performed. The plan should address the following: who is responsible for identifying contacts and notifying exposed individuals? How will such notifications occur? And what actions and follow-up are recommended for those who were exposed? This guidance complements the testing guidance that is specific to dialysis facilities. And before we change topic, we wanted to also let you know about a recent update in the IPC General Guidance. The section on implementation of universal use of PPE or personal protective equipment was updated last week to expand options for source control and patient care activities in areas of moderate to substantial transmission. And it describes strategies for improving fit of face mask. It includes different examples on what is a well-fitting face mask. So we invite you to read specifically that section in the general IPC guidance that can be useful. Next slide, please. Finally, we wanted to mention a couple of NHSN COVID-19 modules. You may already be aware, but the first is a COVID-19 module for dialysis facilities. This module is supporting the nation's COVID-19 emergency response, and the data collected are used for public health emergency response activities by CDC and other federal agencies involved in the response. The NHSN COVID module provides a mechanism to track infection in a systematic way. Having the data in this format will allow you to quickly assess the impact of COVID-19 on your clinic, inform your clinic's response, assist the public health response, and help to resource coordination and allocation. Next slide, please. The second module we want to mention is one that allows weekly reporting of COVID-19 vaccination data through the healthcare personnel safety component. These modules are designed to allow reporting of vaccination coverage for healthcare personnel at a facility, allowing for identification of vaccination coverage gaps and targeting improvement efforts. Facilities can use the data to obtain a better picture of COVID-19 vaccination at their facility. It can help monitor vaccination trends over time, identify groups in a facility with lower vaccination rates. For example, are dialysis techs getting vaccinated at a lower rate than nurses? Improve vaccination tracking, for example, develop an automated tracking system. And importantly, provide jurisdictions with critical information that can guide COVID-19 planning and implementation, including issues with vaccine supply. Data will inform various public health emergency response activities. Thank you, and now I'd like to introduce my colleague Shannon Novosad, who will present information on vaccination for COVID-19. Next slide.
Great, thanks.
Thank you.
Hi, everyone. I'm going to cover some COVID-19 vaccine information. I'm going to actually move through several different topics as I speak. I'm going to try to cover some of the stuff regarding COVID-19 vaccine that we commonly get asked, and then just make sure that I try to give as best as possible kind of an overview of what CDC's role has been kind of in the vaccine rollout. Next slide. So in the 1 year since COVID-19 infections were first identified, multiple COVID-19 vaccines have been developed and put through clinical trials with the support of the U.S. government. So far, 2 have received FDA emergency use authorizations, although you've probably heard the news and that's about to change very soon, I think. And then as of February 8th, over 42 million doses have been administered, and that includes 32 million people who started the vaccine series, which is, of course, currently a 2-dose series, and 9 people being fully vaccinated. Next slide. So delving a little into the ACIP, which is an organization that many of you may already be aware of, or at least have heard about a lot in the news recently. The ACIP was established in 1964 by the Surgeon General of the U.S. Public Health Service and was designated as a Federal Advisory Committee in 1972. The ACIP develops recommendations on how to use vaccines to control disease in the United States. Committee deliberations on the use of vaccines to control disease in the U.S. include consideration of disease epidemiology, burden of disease, vaccine safety, vaccine efficacy and effectiveness, the quality of evidence reviewed, economic analyses, and implementation issues. So a number of different sources of evidence the committee uses. The committee may revise or withdraw their recommendations regarding a particular vaccine as new information becomes available. And importantly, the CDC is the secretariat for the ACIP, but the ACIP is independent of CDC. So voting ACIP members are not CDC employees. Next slide. So the committee's recommendations are forwarded to CDC's director for approval. Once the ACIP recommendations have been reviewed and approved by the CDC director and the U.S. Department of Health and Human Services, they are published in CDC's Morbidity and Mortality Weekly Report, also known as the MMWR. The MMWR publication represents the final and official CDC recommendations for immunization of the U.S. population. And notably, under provisions of the Affordable Care Act, immunization recommendations of the committee that have been adopted by the director of the CDC must be covered by applicable health plans. Next slide. So the ACIP includes 15 voting members who are responsible for making vaccine recommendations. The Secretary of the U.S. Department of Health and Human Services selects these members following an application and nomination process. 14 of the members have expertise in specific disciplines such as vaccinology, immunology, pediatrics, internal medicine, and a number of other disciplines. And 1 member is a consumer representative who provides perspectives on the social and community aspects of vaccination. In addition to these 15 voting members, ACIP also includes 8 ex officio members who represent other federal agencies with responsibility for immunization programs in the U.S., and 31 non-voting representatives of liaison organizations that bring related immunization expertise. Members and representatives serve on this committee voluntarily. Next slide. And so this slide here gives a high-level overview of vaccine licensure and recommendations, and you can see where ACIP and CDC fit into this process on the left side of the slide. Moving across the slide, you can see the other steps that actually happen before ACIP advises on the use of a specific vaccine, including pharma submitting to the FDA for an emergency use authorization, or EUA, which is a mechanism to facilitate the availability and use of medical countermeasures, including vaccines during public health emergencies, such as the current COVID-19 pandemic. And you can see on the far right of the slide, the Vaccines and Related Biological Products Advisory Committee, who reviews and evaluates data concerning the safety, effectiveness, and appropriate use of vaccines. So this is a committee of experts that's actually external to FDA, but provides input upon request to FDA on certain regulatory actions. Their recommendations are non-binding, but are usually followed by FDA. Next slide. So CDC vaccine recommendations are developed using an explicit evidence-based method. Key factors considered in the development of recommendations include the balance of benefits and harms, the type or quality of evidence, values and preferences of the people affected, and health economic analyses. In addition, 4 ethical principles assisted ACIP in formulating recommendations for the allocation of COVID-19 vaccine while the supply is limited, in addition to the scientific data and implementation feasibility. And these were to maximize benefits and minimize harms, to promote justice, to mitigate health inequities, and to promote transparency. Next slide. So while ACIP and CDC make national recommendations, we understand that there will be a level of local adaptation. So the phase recommendations are meant to be fluid and not restrictive for jurisdictions, and it's not necessary to vaccinate all individuals in one phase before initiating the next phase. So you may see phases overlap. And again, shown here on the slide is just the prioritization groups by ACIP, which many of you have seen before, but starting with 1A with healthcare personnel and long-term care facility residents, followed by phase 1B, which includes frontline essential workers and adults 75 years and older. Phase 1C, the remaining essential workers, adults 65 to 74 years, and those 16 to 64 years old with a high-risk medical condition in phase 1C. And then finally, 16 to 64-year-olds without high-risk medical conditions are included in phase 2. Next slide. So just to emphasize a few points I actually discussed on the prior slide, but I think these are important because, again, we get asked about these a lot. While ACIP and CDC, again, make the national vaccine recommendations, we do reiterate there will always be a level of local adaptation. And our guidelines are really not meant to be walls or barriers between phases, but meant to support prioritizing people at high risk of exposure or high risk of severe disease, and that we always anticipated there will be overlap between vaccination phases. We understand that the COVID-19 vaccination program is dynamic and will require ongoing reassessment as the vaccine supply and demand and COVID-19 epidemiology change, and this will inform timing of expansion to subsequent phases. And finally, ACIP and CDC have endorsed the guiding principles of efficient distribution as well as jurisdictional flexibility for COVID-19 vaccination programs. Next slide. So 2 vaccines have received emergency use authorizations from the FDA, one produced by Pfizer and the other by Moderna. Pfizer is authorized for persons aged 16 and older, and Moderna is authorized for use in persons aged 18 and older. Notably, the manufacturers reported that phase 3 trial results demonstrated both vaccines were approximately 95% effective at preventing COVID-19 disease. Both are administered using a 2-dose schedule separated by a few weeks. Both were tested in diverse adult populations that included minorities and older adults, and the data has shown that both vaccines are safe and effective at preventing COVID-19. However, it is currently unknown how long the protection from receiving a COVID-19 vaccine might last. Next slide. So we realize that you might have concerns, and your patients may have concerns about the safety of these first COVID-19 vaccines because they do use a new technology. But it's important to know that the mRNA COVID-19 vaccines were developed based on years of research. So while the technology is new, it's not unknown. mRNA technology has been studied for decades in vaccine trials for influenza, Zika, and rabies. And beyond vaccines, cancer research has also used mRNA to trigger the immune system to target specific cancer cells. And so they were able to really fast track these vaccines because researchers used existing clinical trial networks, like those that study HIV treatments and vaccines, to quickly conduct the COVID-19 vaccine trials. Another critical piece has been the investment in manufacturing, even before the COVID-19 vaccines were proven effective. The U.S. government and vaccine manufacturers invested millions of dollars to scale up vaccine production while clinical trials were in progress, greatly reducing the amount of time between vaccine authorization and vaccine implementation. Because of the great financial risks, the investment in manufacturing normally doesn't happen until later in the development process. mRNA vaccines are also faster and cheaper to produce because they use ready-made materials. Next slide. So what are messenger or mRNA vaccines? So to trigger an immune response, many vaccines put a weakened or an inactivated germ into our bodies, but mRNA vaccines are different. Instead, they teach our cells how to make a harmless piece of what is called the spike protein. The spike protein is found on the surface of SARS-CoV-2, the virus that causes COVID-19. This protein piece serves as an antigen to trigger an immune response inside our bodies. And that immune response, which produces antibodies, is what protects us from getting infected when the real virus enters our bodies. Next slide. So some key points about mRNA vaccines. So like all vaccines, these have been rigorously tested for safety before being authorized for use in the U.S. The technology is new but not unknown. It has been studied for more than a decade. They do not contain a live virus and do not carry a risk of causing disease in the vaccinated person. And the mRNA from the vaccine never enters the nucleus of the cell and does not affect or interact with a person's DNA. Next slide. So some of the key facts about COVID-19 vaccination and some of the common myths that are circulating is that, number one, getting vaccinated can help prevent getting sick with COVID-19. So here, COVID-19 vaccination works by teaching your immune system how to recognize and fight the virus that causes COVID-19 and protects you from getting sick with COVID-19. Two, people who have gotten sick with COVID-19 may still benefit from getting vaccinated. So due to the severe health risks associated with COVID-19 and the fact that reinfection is possible, vaccines should be offered to you regardless of whether you have already had COVID-19 infection. At this time, experts do not know how long someone is protected from getting sick again after recovering from COVID-19. The third, that COVID-19 vaccines will not give you COVID-19. So none of the authorized and recommended COVID-19 vaccines or COVID-19 vaccines currently in development in the U.S. contain the live virus that causes COVID-19. This means that a COVID-19 vaccine cannot make you sick with COVID-19. And then finally, COVID-19 vaccines will not cause you to test positive on COVID-19 viral tests. So if your body develops some immune response, the goal of vaccination, there is a possibility that you may test positive on some antibody test, but not on the other tests that are used to diagnose active infection. Next slide. Oh, next slide. Thanks. So to recap, COVID-19 vaccines are being held to the same safety standards as other routine vaccines. Before any vaccines receive authorization or approval, the FDA carefully reviews all the safety data from clinical trials, and the ACIP reviews all safety data before recommending use. FDA and ACIP have qualified scientific and clinical experts with minimal conflicts of interest reviewing all of the data. And after any vaccines are authorized and in use, both FDA and CDC continue to monitor their safety. Existing systems can rapidly detect possible vaccine safety problems. These systems are being scaled up for COVID-19 vaccine introduction to fully meet the needs of the nation. Additional systems and data sources are also being developed to further enhance safety monitoring capabilities. And I'm just highlighting two of these here on this slide. So the first is the CDC vSafe, which actually I'll go into more detail on the next slide, but you can see the logo for it here. And then one that is run by both CDC and FDA, so the Vaccine Adverse Event Reporting System, or you might have heard it called VAERS. So this is a national system that collects reports from healthcare professionals, vaccine manufacturers, and the public on adverse events that happen after vaccination. It also collects reports of adverse events that are unexpected, appear to happen more often than expected, or have unusual patterns. These are then followed up with specific studies. Next slide. So specifically for VSafe, it's a smartphone-based tool that uses text messaging and web surveys to provide personalized health check-ins after you receive a COVID-19 vaccine. Through VSafe, participants can quickly tell CDC if they have any side effects after getting the COVID-19 vaccine. And depending on the answer, someone from CDC may call to check on you or the person who has reported them and get more information. It can also remind you to get your second COVID-19 vaccine dose if you need one. So we encourage everyone who receives a vaccine to participate in VSafe. All you need to register is a smartphone, and you can talk to your vaccine provider about enrolling when you get your vaccine, or you can visit CDC's website for more information. Next slide. So before vaccination, you should learn more about the different types of COVID-19 vaccines and how they work. During your vaccination appointment, you receive a paper or electronic version of a fact sheet specific to the COVID-19 vaccine you're being offered. And after you are vaccinated, you should be given a vaccine or vaccination record card. Your provider may also give you information about how to enroll in VSafe. And it's important to continue using all the tools available to help stop this pandemic even after being vaccinated. So covering your mouth and nose with a mask when you're around others, staying at least 6 feet away from others, avoiding crowds, and washing your hands often. Next slide. So unfortunately, we know that many people may be hesitant to get a COVID-19 vaccine. So according to this Harris poll conducted in October, before a vaccine was authorized or available, only about half of people said they would get a hypothetical COVID-19 vaccine. There are several factors that can impact vaccine acceptance, including concern about side effects, vaccine efficacy, risk perception, and associated cost. We also know that people will be more likely to get a vaccine if their healthcare provider says it's safe, the vaccine's free, if it helps people get to work or school, and it's easily available. Worries and concerns about COVID-19 vaccine can impact people's willingness to get vaccinated, which is why we need to address them fully so people can be confident in the decision to get vaccinated. Next slide. So how can we address vaccine hesitancy? By building vaccine confidence, which is a multifaceted concept based largely on trust. Vaccine confidence is the trust that patients, parents, or providers have in recommended vaccines, providers who administer vaccines, and processes and policies that lead to vaccine development, licensure, manufacturing, and recommendations for use. A person must have trust in all three of these to feel fully confident in their decision to get vaccinated. Next slide. In order to cover the pandemic, it's critical to increase demand for COVID-19 vaccine. This slide shows how the willingness to accept a vaccine falls on a continuum. The vaccine demand continuum illustrates behaviors, whereas confidence is both a feeling and can be acted on. Most people may fall in the middle of the spectrum with a wait-and-see approach. We want to move people toward the right. So the closer you get to active demand on the right side of the continuum, the increasing confidence a person likely feels in the vaccine, the vaccinator, and the health system because they actually actively chose vaccination, and this is required effort. People vote with their feet. If there's sufficient confidence and trust and ability, then people will seek out vaccines, overcoming barriers to do so. People with less confidence or motivation or ability may have trouble overcoming barriers, such as transportation. It's also important to note that where a person falls on the continuum may depend on whether the person is considering this relative to themselves or others that they care about, such as minor children, adult children with disabilities, and older parents. Next slide. So individuals across the spectrum will have concerns. These concerns are understandable and need to be addressed with empathy and transparency. We also know there's likely to be vaccine hesitancy among healthcare providers. Healthcare personnel are influential when it comes to building vaccine confidence. The general public will be looking at them and taking their lead when it comes to COVID-19 vaccination. If they get vaccinated and recommended the vaccine to patients, this will help increase uptake among their patients, their friends, and families. Communities will have unique experience in forming COVID-19 vaccine perceptions. Engagement with community organizations and leaders will expand access to clear and accurate information on COVID-19 vaccines. Next slide. So this slide shows CDC's Vaccinate with Confidence strategy, which aims to build confidence in COVID-19 vaccine, the providers who vaccinate, and the vaccination system. It's not a communication campaign, but rather a framework for thinking about interventions to increase vaccine confidence. And there are three components to the framework. The first aims to build trust by sharing clear, complete, and accurate messages about COVID-19 vaccine. The second aims to empower healthcare personnel by helping them to feel confident in their own decision to get vaccinated and to recommend vaccination to their patients. And the third focuses on how to engage communities in a sustainable, equitable, and inclusive way to increase collaboration. Next slide. I'll go through the next 3 slides pretty quickly. They just expand really on kind of the 3 objectives I showed earlier, but they go into more detail and kind of discuss what some of the tactics and sample products or tools that have been developed for CDC for each one. So here on this one, for the first component, this discusses, communicating transparently, providing regular updates, and proactively addressing and mitigating the spread and harm of misinformation via a variety of platforms. Next slide. For the second component, which is to promote confidence among healthcare personnel, there has been work to engage national professional associations, health systems, and healthcare personnel often and early to ensure healthcare systems and medical practices are equipped to create a culture that builds confidence and to strengthen the capacity of healthcare professionals to have empathetic vaccine conversations, feel comfortable addressing myths and common questions, and providing tailored information to patients, and using motivational interviewing techniques. Next slide. And then the third component is engaging communities. And again, this involves work with jurisdictions to engage partners and allowing recipients to share their personal stories, working with partners to engage communities around vaccine confidence and to secure delivery strategies, and really collaborating with trusted messengers. Next slide. So to summarize, the Vaccinate with Confidence is not an advertising, marketing, or communication campaign. Really, it's a cohesive framework to support health departments, healthcare providers, and other partners in their promotion of COVID-19 vaccines. It includes evidence-based content to amplify messages that enable an individual to make the decision to get vaccinated, and it's critical to ensuring safe and effective COVID-19 vaccines to control and reduce the impact of this pandemic. Next slide. So some things to start thinking about when it comes to communicating with your patients about vaccines. So as I mentioned, vaccine confidence starts with you. Patients will likely ask you if you've been vaccinated yourself, and if you have not, this could negatively impact their willingness to get the vaccine. It's important to start vaccine conversations early, even before the vaccine is widely available, and learn how to engage in effective conversations and be prepared for questions and be able to state the facts. Next slide. So strategies to improve second dose compliance. I won't go into detail on this slide, but this is one important way that we want to make sure that you're also thinking about improving compliance. So it's not just getting the first dose in patients' arms or your own, it's really making sure that the second dose happens. And there's a variety of different ways to do this, but it does involve a lot of reminders, scheduling appointments ahead of time, and using some of these systems that I've already discussed and that are listed here on this slide, again, to get the reminders to the patients. Next slide. The next couple of slides actually just highlight, again, some questions that we commonly get about the vaccine and who should be getting the vaccine. So here on this slide, they discuss people with a history of SARS-CoV-2 infection. And so vaccination should be offered to persons regardless if they have had a history of either symptomatic or asymptomatic SARS-CoV-2 infection. And it really boils down to just when the timing of when the vaccine could be offered. And so vaccine should be deferred until recovery from acute illness and criteria have been met to discontinue isolation. But there's really no minimum interval between infection and vaccination. Because current evidence suggests that risk of reinfection is low in the few months after initial infection, there are some jurisdictions and other areas that, while vaccine supply remains limited, are waiting to vaccinate these people until a certain time period, but that may change over time. Next slide. people who've previously received antibody therapy for COVID-19. So there's currently no data on the safety or efficacy of COVID-19 vaccination in persons who received monoclonal antibodies or convalescent plasma. But based on the estimated half-life of these therapies, as well as evidence suggesting reinfection is uncommon in the initial 90 days after infection, it is currently recommended that vaccination be deferred for at least 90 days as a precautionary measure until more information is available. Next slide. So protection from the vaccine, again, is not immediate. So currently available is a 2-dose series, and it takes 1 to 2 weeks following the second dose before a person is currently considered fully vaccinated. Additionally, as no vaccine is 100% effective, some vaccinated people may still get COVID-19. So given the currently limited information on how well the vaccine works in the general population, how much it may reduce disease, severity, or transmission, and how long protection lasts, vaccinated people should continue to follow all current guidance, including those listed on this slide, to protect themselves and others. Recently released quarantine recommendations. Oh, sorry, next slide. Recently released quarantine recommendations for vaccinated people. Here on this slide is the vaccine and quarantine recommendations for those in the community setting, and then on the next setting actually discusses what should happen in the healthcare setting. And similar to what was discussed earlier by Dr. Bardossy, there are a little bit of differences between what's recommended for the community setting and the healthcare setting. But the bottom line here is that vaccinated people with an exposure to someone with suspected or confirmed COVID-19 in the community setting are not required to quarantine if they meet all 3 criteria listed at the top of this slide. So they're fully vaccinated within 3 months of receipt of the last dose, and they have been asymptomatic. If they don't meet all 3 criteria, they should continue to follow current quarantine guidance. Next slide. And then this slide here covers the quarantine recommendations for healthcare settings. And so kind of as an exception to the guidance on the previous slide, vaccinated inpatients and residents in healthcare settings should continue to quarantine following an exposure to someone with suspected or confirmed COVID-19. Outpatients should be cared for using appropriate transmission-based precautions. And this is due to the unknown vaccine effectiveness in this population, higher risk of severe disease and death, and challenges with social distancing in healthcare settings. Next slide. COVID-19 vaccination, again, is an important tool to help stop the pandemic, but it continues to be only one tool in the toolbox. So both getting a vaccine and following other CDC recommendations is the best way to protect yourself and others, which I know I've said several times already, but just wanted to reiterate that again. Next slide. So again, this is an exciting and historic time, but the work is far from over. There will be unanticipated challenges, but CDC will continue to work with our partners and you to find solutions and overcome obstacles. Vaccines are an important tool to control the pandemic, but we need to continue messaging all of the other important tools to other colleagues and patients, and community engagement is critical to the vaccination implementation success. Next slide. And this here just discusses what you can do now. I think we've already discussed many of these already, so I won't repeat them here, but you can read them here on the slide. And then next slide. Here just shows some of the CDC resources for some of the issues that we've covered about vaccination. And then next slide. And then thanks, and I think we're available for questions.
Great, thank you so much. I know there was a lot of information, and it's that you shared with us today, and a lot of resources. But again, these slides and the recording will be posted to our website within 3 days, so you can always go back and get those links and where those resources are located. We do have some questions that came in, and again, if anybody has any questions, please feel free to submit them through the chat or the Q&A. But I think we'll jump into a couple. One question says, how can we make dialysis patients a priority in getting the vaccine?
Hi, this is Shannon. Yeah, I will give my thoughts on that, but also welcome Dr. Bardossy and Stephanie if they have comments as well. So I think that's a question that can actually have multiple phases, and I think it, starts at a very local level. I do think, again, we covered a little bit of the ACIP recommendations early on, and currently dialysis patients are in the 1C group, the group with chronic medical conditions, unless they fall into one of the other categories, for example, a long-term care facility resident, or if they meet some of the age criteria in the earlier phases. But there are certain jurisdictions who have already prioritized dialysis patients and facilities and have given them vaccine to cover all their patients, not just ones in some of the earlier phases. So I think starting locally with your local public health departments and jurisdictions, I think advocacy is important, and ensuring that this is a population that they're thinking of when they're thinking about how to prioritize vaccine. And I do think some important messages that are helpful to relay are some of the facts about dialysis facilities that everyone on this call probably knows, but some may not, who are not familiar with the setting, may not know. And I think it's the ability of dialysis facilities to provide the vaccine, since this is a service that they provide for their patients anyway, for other types of vaccine. So providers that are very comfortable and capable of providing vaccine. It's a location where dialysis patients that were expecting to receive the vaccine. And it's, for lack of a better word, kind of a captive audience of patients there. So when your patients are coming, and they'll be coming back to get the second dose of vaccine. So I think starting efforts locally with those messages is really important.
Thank you. Thank you. I have another question. I have heard that the new Johnson & Johnson vaccine is soon to be released and is a one-dose vaccine. How is that different from the two-dose vaccine that are currently being used by Moderna and Pfizer?
Yes, so that is correct, and I haven't quite kept up with the news today, but I believe that vaccine, actually just today, it was recommended to the FDA to be approved for an EUA. So I suspect that any day now that will kind of officially go through, and then the next step in that process will be that the ACIP reviews the safety data and all of the information from that vaccine and makes a recommendation that vaccine be used. The couple of differences, it is a one-dose vaccine, so different than the two-dose vaccine series that is currently being given. So that's one of the big differences. I actually am not 100% up to speed on what some of the transportation or carrying issues with it. So it could be different from the current vaccines in terms of how it can be transported in terms of temperature and storage. And it is a slightly different vaccine in terms of its mechanism of action. So instead of it being an mRNA vaccine, which is what we focused on in this presentation, its mode of action is a little bit different. So I think in terms of, discussing it with your patients, obviously I think the 1 versus 2 dose will be very important to make sure that they're aware of, because that 2 dose is what everyone has been hearing about on the news or seeing, friends or family get, and they may have questions about kind of the mechanism of action. So I think being able to answer those 2 questions for the patients will be really important.
Great. Okay. Yeah, thank you. Changing daily, right?
Yes, it is definitely changing daily.
Right. Dialysis patients are hesitant to get the vaccine because there were no dialysis patients or ESRD patients done in the trials. What can, as clinical staff and working in the dialysis, what do you suggest we say to these patients to encourage them to get the vaccine?
Yeah, no, I think that's a great question, and I agree. As far as I know, yes, there were few, if any, dialysis patients included in most of these trials. I think the important messages I would want to make sure to answer or get across with that is that while there were no dialysis-specific signals we'd be able to see related to dialysis patients in terms of safety, The vaccines overall were very safe, and and all of the participants that they were studied in, and that we don't necessarily have or have seen previously, with other vaccine trials or other vaccine therapies, evidence that in terms of safety profile and stuff, it would necessarily be different in dialysis patients versus other patients. So I think when communicating with patients, it might be important to separate some of the issues of safety and efficacy. At the same time, I don't want patients to think it's not efficacious in their particular populations either. But I do think if you can really hone in on the safety message with patients up front, that's really important. And discuss how, there will be a lot of work ongoing, once, groups have been vaccinated, to understand kind of the durability of the vaccine response in specific groups. And obviously dialysis patients would be a very important group we would want to understand vaccine effectiveness in, and duration of response, because that very well could be something that could be different than the general population.
All right, great. Thank you, ma'am. Another question, I know this probably, again, changing daily, but what is this variant strain, and will the vaccine still work?
No, I think these are all very good questions. I wish I had specific answers to more of them, but I do think we're learning more about the variants every day. And I think there's definitely work to do with the vaccines and understanding exactly how efficacious they are against certain strains or different variants. I mean, I think the main message now is that we're just still learning, and we are going to have to be testing, different vaccines against different variants as they arise. But right now, the recommendation is still to get the vaccine, get these vaccines despite whatever variants might be particularly circulating in your community. I also think one thing that's important to discuss with people about the variants is that the more people that we're able to get vaccinated and the more we're able to prevent transmission of COVID between people, the less likely we are to see these variants develop. So I think there's potentially kind of two different avenues to discuss with patients or others when that question comes up. One, we're obviously, unfortunately, are still learning, but it's still very important to get the vaccine until we know more about a specific vaccine versus another. But it's also important in general to get the vaccine, to avoid having new variants continue to develop.
Right, good. Well, thank you. I think we are going to, we're just about 3 minutes to the top of the hour. Again, thank you to all of our speakers, Dr. Bardossy, Dr. Novosad, and Ms. Booth, for being here today. We're going to go ahead and wrap up, so I could have the next slide. I do want to just remind everybody, we do have a flu vaccination toolkit on our website. It's a toolkit for providers featuring, facts, taglines, social media content, videos, on-demand training and educational events, and a lot of materials are ready to print. So please visit esrdncc.org /flu today. Next slide. And as a reminder, we have inspirational posters also available on our website. These are evidence-based posters you can print. They focus on psychological, physical health, emergency preparedness, and of course COVID-19 that you, again, available to print on demand, and that you can display in your dialysis unit or your facility or organization. Next slide. And the Kidney Hub. This is a mobile-friendly based tool that was created with patients for patients. It links to new videos and helpful resources. They're being added and updated on a regular basis. They include such things as home dialysis, COVID-19, transplant. There's also information about diet and nutritional resources also. So please visit www.thekidneyhub.org today and get more information. Next slide. And just as a reminder, we actually have our next provider-focused event will be March 10th, 3 p.m. Eastern Time. And then our next COVID-19 patient-focused event will be March 16th at 4 p.m. Eastern Standard Time. And again, I just want to thank everybody for attending, taking time out of your day to be with us, and also to our speakers to take time to keep us updated in this ever-changing landscape with COVID-19. They've provided a lot of good resources and links today, again, that will be available in our website in about 3 days. So thank you again, everybody. Thank you for being here. Take care and stay safe.